All right, I think it's noon, so I'm going to go ahead and get started. I'd like to thank all of you for joining me today to talk about uterine artery embolization, a treatment option for symptomatic fibroids. I'd also like to thank our organizers for setting this up so that we can have this discussion today. Obviously, I'm going to be talking about this procedure in some depth during the course of this talk. But one thing I really want to get across here in the beginning, and I'll repeat it again at the end, is I'm not here to tell you that uterine artery embolization is the best treatment option for symptomatic fibroids. It's just one of multiple options that we thankfully have, and each option has its own advantages and disadvantages, which we'll cover. Different people have different priorities as to what they want to get out of any given procedure. So you're much better positioned to make an educated decision as to which option you want to go with if you really know the differences between the different procedures and the advantages and what suits you best. So what may be true for one woman with symptomatic uterine fibroids may not necessarily be true for the person sitting next to you. I don't have any financial disclosures. So a few talking points. We're going to be discussing what is uterine artery embolization, of course, when is it needed, what can I expect if I have one, what kind of outcomes could we be looking forward to, who should not get a uterine artery embolization, so it's not necessarily a good option for everybody, and how does it compare to other procedures that may be alternatives. Most commonly, those are going to be hysterectomy and myomectomy. So I want to take a step back first and talk a little bit about abnormal uterine bleeding. Abnormal uterine bleeding is a relatively common but complicated phenomenon. Now recently we actually had another physician, one of my colleagues, Dr. Al-Najjar, who gave a talk about abnormal uterine bleeding, and I think she actually did a really good job of going into in depth about the topic and explaining in really a lot more detail of what I'm going to be doing about abnormal uterine bleeding. So I really recommend, if you're interested, to go back online and watch that video. But to put it briefly, the American College of Gynecology defines abnormal bleeding in somebody who is not pregnant, who has abnormal regularity, volume, frequency, and duration of their menses. So normal menses is about 5 days every 21 to 35 days. So if you're bleeding too heavily during those 5 days, that's abnormal. If you're bleeding outside of those 5 days, that's abnormal. If you're bleeding for a lot longer than 5 days, that's abnormal. And if you're bleeding kind of irregularly, kind of throughout that whole cycle, or it's not every 21 to 35 days, but it's just kind of there's no clear pattern to your bleeding, that would also be considered abnormal. So there are multiple different causes of abnormal bleeding, which we're going to go through briefly as well. So they're split into two common categories: structural causes, which are usually causes of anatomic pathology over here, and then we have non-structural causes, which are usually biochemical issues that are causing your bleeding. So going through structural causes, we have first is polyps, abnormal growth inside the cavity of the uterus. Adenomyosis is something we're going to discuss briefly towards the end of the presentation. Leiomyomas, which is the medical term for fibroids, and malignancy and hyperplasia, so cancer and precancerous conditions, all of which can cause abnormal uterine bleeding. Coagulopathy is the first of the non-structural causes. That's just people who have a tendency to bleed a lot anyways. Ovulatory dysfunction is usually a problem of ovulation, which is often related to a hormonal dysfunction. Endometrial is a component, the inner lining of the uterus, that often, if it has abnormalities, is also a biochemical issue. Iatrogenic is a problem that was caused by a physician, generally speaking. So you've had some kind of procedure, perhaps maybe you had a biopsy, and you've had bleeding that just won't stop. And then if there's a reason that doesn't really fit very cleanly into any of these other categories, we just kind of put in this catch-all, not yet classified category. So of course, what are uterine fibroids? They're non-cancerous growths in the uterus. They do not turn into cancer. They don't increase your risk of developing a cancer, and they can grow on different parts of the uterus. So this picture here is a very nice illustration of uterine fibroids in different parts of the uterus that can be affected. And this is going to be very important to understand some portions of the rest of the talk. So I'm going to walk you through it. The light pink areas is the muscular portion of your uterus, and this kind of triangularly shaped dark red area is the cavity lining on the inside of the uterus. So the most basic type of fibroid is what we call an intramural fibroid. This is a fibroid that's just mostly positioned within the muscular layer. So that's kind of your baseline fibroid. A subserosal fibroid is similar to the intramural fibroid, but it's starting to bulge out towards the outer margin of the uterus. And you have a submucosal fibroid, which is a fibroid mostly in the muscular layer, but it's starting to bulge towards the inner lining of the uterus. And then you have two other categories, what we call pedunculated fibroids. So here we have a pedunculated submucosal fibroid, meaning that the fibroid is primarily within the cavity inside the uterus, but it's still attached to the muscular layer by a thin stalk. And then the opposite of that would be a pedunculated subserosal fibroid. Again, it's mostly outside the uterus, but it's connected by a thin stalk. Now, there is a quiz at the end of this presentation, so you got to remember all of these, okay?
Now, can you have more than one type at the same time?
Absolutely, yes.
Okay. And how many can you have at one time? 2 or 3 or 20 or?
So it varies significantly from woman to woman. Some women could have just one fibroid, and that can be enough to cause significant symptoms, and some women can have a lot of fibroids, in the range of 20 or so. So who gets fibroids? Women of childbearing age typically. They tend to start to grow between 30 and 40 years old. And about a little under half of women by 40 years old will have fibroids. Now, we're not 100% sure why. We haven't quite figured out exactly the reason behind it. But black women tend to have fibroids more commonly. They start to grow earlier, they grow faster, and they tend to be more symptomatic than women of other races. Other factors that may influence your likelihood of developing fibroids are if you have first-degree relatives, which means mother or sisters and daughters who have fibroids, puts you at a higher risk. There does seem to be some genetic predisposition to developing fibroids, which makes sense based on what I just said. Women who eat a lot of red meat and not enough green vegetables tend to have a slightly higher risk of fibroids as well. And overconsumption of alcohol as well has been associated with having a higher risk of fibroids. So what kind of problems can they cause? Thankfully, most women who have fibroids will never have any symptoms from them, and a lot of them will never even know that they have fibroids. It's if they had some kind of imaging study for a different reason, we'll say incidentally, you got some fibroids. But thankfully, not usually a problem for them. But for the other 25% of women, they can cause heavy bleeding or painful periods. And as I mentioned before, when we're talking about abnormal uterine bleeding, you can have bleeding in between periods as well. Fibroids can also cause pressure, pain, or fullness in your lower stomach. And this is what we tend to call bulk symptoms. So your fibroids are so bulky that they tend to be compressing nearby structures and causing symptoms. And sometimes women have only bleeding predominant symptoms. Sometimes they have predominantly bulk symptoms, and you can also have both. And if you remember back to the picture of the different types of fibroids, oftentimes, depending on where your fibroid is and what size it is, that's going to determine what kind of symptoms you're primarily experiencing. So if you look at the pictures on the right, at the top this is an MRI image looking from the side of a woman who has a fairly normal looking uterus. So this is the uterus right here. That's what it's supposed to look like. And this is just for reference her spine. So this is her back and that is her front. This is somebody who has a very large fibroid, okay? And you can see pretty easily that it can be causing compression against nearby structures. So depending on what it's pushing against, you can have different symptoms, such as constipation. If the rectum is down here and it's getting squished by this fibroid, then that is going to lead to constipation. It can make you feel like you need to urinate more often or trouble emptying your bladder. This white ovoid structure here is the bladder, and you can see how it's getting squished by the fibroid.
Okay, talk about the size of an orange or a grapefruit, or how large can they grow?
They can get pretty large. I've seen women, this is now very large, this is not typical, but women who have fibroids growing all the way up almost to the of their liver. Yeah.
Wow.
Pretty big. And they can cause pain during intercourse as well. Because fibroids can get quite large, they can also lead to increased risk of miscarriages and infertility. Either it makes it difficult for the embryo to implant on the uterus, or if you do have successful implantation, you can imagine somebody who has a fibroid this big, that baby's not going to have that much room to grow. And so that would unfortunately lead to miscarriages. If somebody has a fibroid that big, you can generally get a pretty good sense that there's something going on just by doing a physical exam. Just kind of pushing against that area, you might be able to feel a mass. But a small fibroid is going to be pretty difficult to tell that it's there just by pushing on the abdomen. But because it's something that you're already in the office when we're evaluating for, we just do it, and we can often tell that way how big a fibroid is. But just because you feel something doesn't mean it's fibroid. Yes?
Are they solid or fluid too?
They are solid. They are solid. So once you've kind of determined that there's something going on, either you're having too much bleeding or you're having pain, or when they get that big, a lot of women can say, hey, I feel like there's something there. I feel heavier. I feel like there's some fullness in my pelvis. Something is going on. We need to do something to evaluate that. So even if you can feel something, you just kind of know there's something there, but it's not sensitive enough to be able to say, well, this is what this is. So usually you're going to get some type of radiologic examination to help figure that out. So we usually start with ultrasound. Ultrasound is a relatively quick, cheap, non-invasive method that can give us an idea of what's going on in the pelvis. So it's a really good first tool to use. We're often able to differentiate different types of masses in the pelvis from other types of masses, but that's not always the case. So if we're able to see on the ultrasound, hey, this looks like 1, 2, or several fibroids of various sizes, and we're very confident that that's what this is, then that's usually good enough, and we stop there. But if there's something, we're a little unclear about something, or we need to do a little bit more problem solving, oftentimes we move on to an MRI. We don't like to start with the MRI, even though it does give us better images in more detail, because it is more expensive and it does take longer to do, and it's not necessarily always the most comfortable if you have issues with claustrophobia, because the tubes can be pretty tight. So we usually like to save it for only when we really need to do it. But it does help us to kind of evaluate a little bit better what's going on if we're not sure based on the ultrasound. Hysteroscopy is an examination that is typically done by a gynecologist, where they use a special type of scope and they insert it vaginally, and they're able to look through an eyepiece, and they push the tip of it through the cervix into that cavitary portion of the uterus, and they can better tell what's potentially causing your symptoms. Now, they won't be able to see something on the outer lining of the uterus, but if there's something within the cavitary portion, either a pedunculated submucosal fibroid, which is the fibroid really sticking inside the uterus, or a fibroid that's bulging towards the inside of the uterus, they may be able to pick that up. And of course, this can be used to find pathology that's completely unrelated to fibroids. Hey, maybe you have a problem with the endometrium itself, or you have some other type of mass that may be causing a problem. So this is often very helpful and is usually determined by the gynecologist as to whether or not it's worth doing in your specific situation. Usually, as a general concept in medicine, before we want to do something invasive and potentially irreversible and making some cuts into the body, we want to try to start with the simple things first. In this case, that would be medications. So most women will have medical treatment of fibroids before they move on to a procedural treatment. If you're on birth control or some type of hormonal medicine, then usually we would stop those medications. Now, somewhat paradoxically, we would sometimes put women on birth control because it can help improve the bleeding type of symptoms that you get with fibroids, but even though it can actually cause your fibroids to grow. Another class of medication are something we call GnRH agonists. One common one that we use is called Lupron, that some of you may have heard of. It's an injection, and it blocks the production of estrogen and progesterone. And this actually works quite well in improving the symptoms that a lot of women have, whether they're related to bleeding or the bulk and size of the fibroid. The problem is it's not a very good long-term solution, because if you use it for too long, it has a high risk or a fairly high risk of leading to osteoporosis. And what we really don't want to do is we're not trying to fix one problem by causing another one. A lot of physicians believe, and most research seems to indicate, that once you reach menopause, fibroids tend to involute, meaning they start to shrink and kind of wither away and die. So some of these shorter term options are not a bad idea for women who are maybe so close to getting to that point that we just need a short kind of bridge or a gap to get us to that point, and then hopefully the body will just kind of take care of the rest. Other options would be putting in an intrauterine device that excretes progestin, and that can often help control bleeding type symptoms. And tranexamic acid is a medication. It's non-hormonal, and it's usually used on heavy bleeding days, so it's not something that can be used chronically. It's an IV medicine, so you have to be at a facility like a hospital where they can give you that medicine, and so you'd have to keep doing it anytime you had any heavy bleeding episode. So if your bleeding is for some reason thought to be a short-term problem, it's a pretty good option, but if this is going to be a chronic problem that's going to be going on months or years, it's not a very good solution for that. And this is an area where the talk that I had previously referenced to about abnormal uterine bleeding that was previously given, she goes into a lot more detail about medical treatment of fibroids, or medical treatment really of abnormal bleeding in general, that I think would be helpful. So now I'm going to go on to the surgical or procedural treatments of fibroids, and we're going to talk a lot about uterine artery embolization. Of course, that's the main topic of this discussion, but we're going to talk a little bit about some of the other options as well. So first, what is an embolization? What does that mean? Embolization is when a blood vessel becomes blocked. In this case, it's something that we are intentionally doing. A lot of people have heard the word embolization when people have blood clots in their lung. That's what we call a pulmonary embolism. And that's when a blood clot, usually from the leg, has traveled upwards, and so that's embolized the plug. That would be a case of an unintentional embolization. Here, this is something we are intending to do. So uterine artery embolization, it's minimally invasive. It blocks the blood vessels that are supplying nutrients to the fibroids. Fibroids, just like everything else in our body, require nutrients to grow. Truly, fibroids are benign tumors. So it takes the nutrients that's in our vessels, and they continue to grow uncorrected. What we do by blocking the nutrients is that if we can get large fibroids to shrink and small fibroids to disappear completely. How do we do it? First, we make a small incision either in the wrist or in the groin. Traditionally, this was done through a very small incision in the groin, but as we've gotten a little bit more sophisticated in our techniques, we're able to do it from the wrist now. They each have their advantages and disadvantages. Because people have been doing it from the groin for a much longer period of time, there's a lot more experience with that. But there are some advantages in the wrist, in that we'll talk shortly afterwards about what happens after the procedure is done. But when you go in from the groin for any procedure into artery, you have to lay flat on your back for at least 2 hours, if not even up to sometimes 4 hours. And when somebody tells you you cannot move, there's nothing more in this world that you want to do than move. So when we go in through the wrist, that's really not really much of a concern, and so you could really get up and walk around and do whatever it is that you want to do once the sedation has worn off a little bit. Yes, sir?
Why is that? Why is it 4 hours when it's in the groin and not a problem in the wrist?
Sure. So when we do the procedure through the wrist, there's a special type of bracelet that we put on afterwards that keeps the blood from evacuating. We're not able to do that for the groin. So sometimes we're able to put in a special type of device that helps plug up the hole that we made to get into the blood vessel, and that's when it deploys successfully, which thankfully is most of the time, you still have to lay flat for 2 hours. But if we're not able to put in the plug, then it's at least 4 hours. So once we're in, we have a catheter, which is a plastic tube that we use to get into the blood vessels that are supplying the uterus. And I think my laser is kind of going out on me, but you can see here, let me go to the mouse. Over here, you can see that there is an artery that is going directly towards the uterus. And so we use our knowledge of anatomy to help guide us there. And once we're there, we're going to inject some contrast dye material. And that shows us where we are and just as importantly, where we need to go. So here's an example where somebody has, in this particular patient, they elected to go from both groins, and so we have injection from both sides at the same time. And so this large kind of ball-shaped structure is a fairly sizable fibroid. And once we get the catheter into the position that we're happy with, we inject a large number of these small particles to block those vessels. This whole process takes about 1 to 2 hours. So what's going to happen next? The most common side effects are going to be pain, cramping, and nausea. And these can be fairly intense. We do give a lot of medicines during the procedure to help keep the comfort as much as possible. And the procedure itself is actually not very painful. You can't actually feel anything that we're doing on the inside. The only parts of the procedure you feel are really when we're actually in. And we usually do one half initially, and then we move to the other side and we immediately do the other side. So sometimes once we finish the first side, you can start feeling a little bit of that cramping sensation come on. And then usually by the time we're done, you have kind of the cramping from both sides at the same time. So for that reason, we're going to keep you for several hours because we want to be able to give you IV medicines to help keep the pain and nausea and cramping as controlled as much as possible. If you're doing pretty well, then you get to go home, sleep in your own bed. If you're still having a lot of pain or nausea that we feel like is not going to be well controlled by the pills that we're going to give you to go home with, we'll keep you in the hospital for a day, make sure that, for a night I should say, make sure that by the next morning you're doing better, which just about almost everybody is, and then you get to go home. And we're still going to give you medicines to go home with. Once you're home, the pain and cramping is worst for the first few days after the procedure, but generally speaking, the medications that you're going to get are going to be sufficient to keep those under control. Most women, anecdotally that I have had experience doing this with, are able to get back to work in about 2 weeks. And the procedure starts to work pretty much instantaneously, but it does take about 3 months for most women, and in some cases a little longer, maybe 6 months, to really get to the full effect of the procedure. Everybody, of course, wants to know, did it work? That's the first question they say when we're done with the procedure. So to clarify that, I'm going to just talk very quickly about technical success versus clinical success. As I said before, the goal of the procedure is to block the arteries that are supplying the fibroids. That's what we call technical success. Were we able to block both arteries, one on each side, that are supplying the uterus and therefore the fibroids? And the answer overwhelmingly is yes. 95% of the time, we're able to do that. So that's pretty good. As important as this is, what's more important is, well, okay, you block the blood vessels. Am I going to get better? That's, of course, what everybody wants to know. Thankfully, the vast majority of women, 80 to 90%, will require no further treatment. Over 85% of women, if their bleeding symptoms are what's predominating, they're going to have a significant decrease in their bleeding. Over 90% of women who have compression or the bulk symptoms as their leading problem that cause them to seek medical attention, more than 9 out of 10 of them are going to have decreased compression on nearby organs. The uterus as a whole generally will become smaller by about 35 to 40%, and the fibroids themselves will usually shrink to about half their size initially. You may be thinking that you showed us that picture of the lady with the really big fibroid in the beginning. Even if you shrunk that to about half its size, that's still a really big fibroid. So how does that work? That fibroid didn't get to that size overnight. That was a very long process, typically speaking, for it to get there. The body is really good at adapting. So it's formed ways, it's kind of gotten used to the size of that fibroid. So even if we're able to get that fibroid to half its size, the adaptation that the body has made to kind of live with that, when you get to half that size, it's almost as if it's like, oh, well, now I can really do whatever I need to do just as well as if this fibroid was almost not even there. And that's why even for fairly large fibroids, we still have pretty good success, even if the fibroid is still there on follow-up. Of course, we're always looking for how can we make the procedure better. Well, really the most important thing is this procedure is most commonly done to treat fibroids. So we really, really want to make sure that fibroids are what's causing the problems that are causing you to present with in the first place. The thing that we're most worried about always is that because fibroids are such a common phenomenon that we had discussed, that a lot of people can have fibroids, and they can also have something else. The one we worry most about is cancer. So we want to make sure we're not seeing the fibroids as a red herring, and we're kind of losing sight of what's more important here. And so cancer screening is of utmost importance. American College of Gynecology says cervical cancer screening starts at the age of 30. And if you're HPV virus positive, then you need to have that every 3 years. And if you're negative, then you can do it every 5 years. But that's very important because we want to make sure that you don't have cervical cancer, that's what's causing your bleeding, and you just happen to have fibroids at the same time. So in the same type of analogy as that is endometrial cancer. Particularly women who are over 45 years old, if you had an ultrasound or an MRI that showed some type of abnormality of your endometrium, before we do the procedure, we would usually get an endometrial biopsy. We want to make sure that that's negative before we can move on for the rest of the procedure. We talked about how ultrasound is a good start for evaluating pelvic problems in general. And so just about everybody who's going to get uterine artery embolization is going to have at least an ultrasound. Like I said before, if the ultrasound is so clear that we're pretty confident that there's just fibroids, there's nothing else going on, then oftentimes that'll be good enough and we can move on to the procedure. If there's any suspicion that there may be something else going on, we're going to get an MRI. And there's a lot of interventional radiologists, such as myself. I actually really like to have the MRI kind of anyways, because sometimes it'll actually change the technique and how we do the procedure. Minor variations that are really generally inconsequential to whoever's getting the procedure done. It's not anything that's going to really change what you're going to experience or what you're going to go through. But it does sometimes change our approach a little bit. So sometimes the MRI is helpful for that. And in very, very rare circumstances, which we'll talk about a little bit, maybe something we thought was a fibroid turns out to be something else. The MRI is going to be the most sensitive test to evaluate for that. So we see something on the MRI that we say, hey, wait a second, maybe this thing that we thought was ultrasound on the ultrasound was a fibroid. This may be cancer, for example. Maybe we need to go in a different direction other than the uterine artery embolization. Of course, we want to make sure that you're not pregnant before we do this procedure. We don't want to inject material into the body that's going to cut off blood supply that the fetus is going to need to grow. Yes, ma'am.
So, is there blocking the blood flow to the uterus? You are rendering it non-functional, possibly, so that the woman becomes sterile after?
So, not quite, and we're going to get to it. Every procedure has potential risks. Every procedure is a balance of benefit versus risk, and then you have to decide whether that benefit is worth taking upon that risk. The arteries that are supplying the uterus are very close to arteries that are supplying nearby structures. So a portion of your bowel, your bladder, some nerves in your pelvis, and your buttocks. If some of those particles that we're injecting happen to go into some of those arteries instead of the arteries that we intend, then you could have developed symptoms depending on where those particles go. Having said that, as technology has improved, as our imaging during the procedure has improved, as the catheters or the plastic tubes that we use have improved, we're able to much better see where we are. We're much better able to get deeper into the arteries than we ever have been able to before. And so while, yes, this is absolutely a possibility with any type of procedure that we block blood vessels, this is extremely, extremely rare in today's day and age. Sexual dysfunction is something that is also quite uncommon. It's probably a little bit more likely as opposed to this top category because there is a branch that is very close to the uterine artery that does also supply a portion of the vagina and the cervix. And if that one happens to get blocked, doesn't necessarily mean you're going to have sexual dysfunction, and most women do not, but it is maybe at a slightly higher risk than, for example, the arteries supplying your bowel or your bladder. Early menopause is something that has been seen as a result of this procedure, more commonly in women who are already over 45 years old, so meaning they're getting pretty close to menopause anyways. Your ovaries are supplied by different arteries from the arteries that are supplying your uterus, but they often, in a lot of women, have some connections. So sometimes when we block the blood vessels that are supplying the uterus, then we may be partially blocking the arteries that are supplying the ovaries as well. And so if you think about it, even though the arteries to the ovaries may have supply from different other directions, that small amount of blocking that we're doing is kind of the straw that broke the camel's back. And that's just enough to kind of send the ovaries into permanent dysfunction and really kind of push you towards menopause. Very rare in women under the age of 45. And even in the age of 45 and older, it's still not very common, but it is something that has been seen before. Now, I can tell you out of experience, and most of the women that I've done this procedure to have been in this category, and I can tell you I don't think any of them have actually been pushed to early menopause, but I don't think any single one of them, actually all of them have asked me, if you can, please, please push me to menopause. I wouldn't mind at all. Let's stop this bleeding once and for all. But even then, it's pretty uncommon.
Do I understand you right that in different people there's a little bit of differences between their blood vessels and stuff?
Yes,
Okay.
yes. So there's a lot of differences that can be in our blood vessels throughout our body, but I would say the pelvis seems to be by far the area of the body that has the most variation from person to person. And to some degree, we are over-engineered in the vessels in our pelvis in that most of the structures in our pelvis have a lot of different areas of blood supply. So you can block one blood vessel supplying a certain organ, and there's going to be several others immediately to take over its place to make sure that the body is okay and it's not having any major problem. And for that reason, that's why these top two issues are usually not that significant. The procedure can lead to vaginal discharge or an infection developing. Thankfully, not very common, but this can range from a very minor infection where we need to do nothing or just antibiotics alone would be sufficient. And it can be in rare circumstances a very major infection that would actually require you to remove your entire uterus to keep it under control. If you had the type of fibroid that we saw in the beginning that is almost completely within the cavity of the uterus and it's connected by that thin little stalk, and when we did the procedure, we blocked the blood vessel, and that stalk kind of withers away, that fibroid is going to detach, and it's just going to sit inside the cavity of the uterus. And then you have a piece of tissue that's just sitting there, and the body's not going to like that very much, so it's going to try to push it out. So in essence, the best kind of analogy that I can think of is you're going to deliver that fibroid. And it's not very common at all. You can see only 1 to 2%. And it can be a little bit concerning if you don't know what's going on. You're like, what's happening? Something is not right. And so you can start calling your doctor. But once we kind of figure out what's going on, it's not a big deal. You come to the hospital, we take that fibroid out, manually extract it. Sometimes we'll need to go on to a hysterectomy. This can be for different reasons. One, like I said before, if you have an infection that's so severe that we need to just get the whole thing out to keep that infection under control, that would be one reason. And the other most common reason is, I had mentioned, thankfully, the results of the procedure are generally quite good. But if you happen to be in the minority of women who didn't quite get the results that we were looking for, then sometimes some of them will elect to just get a hysterectomy thereafter, as opposed to repeating the procedure, which is an option, or getting a myomectomy, which we'll talk about a little bit. And then again, something that I've mentioned before, we want to make sure that there's not a cancer going on at the same time, and that's causing the symptoms that you're having. Despite our best efforts, it can still happen. Thankfully, very, very rare, less than 1%. But because we're blocking the blood vessels, what in essence we're doing is we're kind of pausing the growth of that cancer to some degree, and then the symptoms tend to get better, and so we kind of relax, we sit back and relax, and then that cancer eventually is going to start growing, and it may not have the same bleeding symptoms you were having before because those blood vessels are blocked. And so it may cause a delay in diagnosis and therefore, of course, treatment. Thankfully, not common at all. What about death? Everybody wants to know. Risk of death. There are some women who have died from this procedure. Very, very, very rare, and usually due to very abnormal connections where beads ended up going to areas where we didn't want, but not in the same way that I described before. Or because they just really didn't move around very much after the procedure, and so they developed blood clots that then caused them to die. Let me go back to this real quick. This procedure has been done over several 100,000 times in this country alone, and on last count when I checked while making this presentation, only 5 women have actually been reported to die from this procedure. So very, very safe. Who should not get uterine artery embolization? Again, pregnant women, that's kind of obvious. If you have an infection, you don't want to get this procedure done because it's only going to get worse after the procedure. When we have an infection anywhere in our body, we need blood supply so that it can carry the appropriate types of cells to fight that infection, or antibiotics if we're going to be on antibiotics. And if we're blocking the blood from reaching there, then your body's going to have a harder time fighting that infection. If you have cancer, again, if you have cancer, same reason we discussed before, If you have fibroids that are really small, we usually don't treat them because fibroids that are less than 1 centimeter in size usually are not significant enough to be causing major symptoms. They're clearly not large enough to cause the bulk type of symptoms, and usually fibroids this small don't cause very, very significant bleeding. So for that reason, we usually say maybe the bleeding is from a different cause. Let's not do this procedure today. We talked about Lupron as being an alternative, a medical treatment for bleeding fibroids. And let's say that you still want to get the procedure done. What the medication can do, it makes your blood vessels smaller. And so it makes it harder for us to actually get to where we need to go. And it makes it more difficult for us to get as many of those particles or beads to where we want them to go. So usually what we do is we just wait a few months. The effect of the medication eventually wears off. You go back to your normal kind of anatomy, and then we'll be able to do the procedure better. This last topic here is somewhat of a contentious topic. We used to say that you should only do this procedure if you have no desire for pregnancy, because we're blocking the blood vessels to the uterus, and so maybe the uterus may become non-functional, or it doesn't have quite enough blood supply to be able to carry a pregnancy to term. But a lot of women, now that the procedure has been done so many times, a lot of women have successfully gotten pregnant after this procedure, and they have carried those pregnancies to term and had normal babies. Compared to the normal population, yes, your risk of having an abnormal pregnancy or a miscarriage is going to be higher than the average population. But that's also going to be true of any procedure that you're going to do to help try to correct these fibroids. We used to think, and I'm sure there are plenty of people who still think, that some of the alternative procedures are perhaps better suited for women who want to become pregnant, and that may be true, but we don't have any real good data that absolutely shows that to be true. So in reality, we don't really know what is better, uterine artery embolization versus one of the alternatives for women who might be pregnant. But we just can say anecdotally, we know that women have definitely been able to get pregnant. There are plenty of women out there who were able to successfully get pregnant after this procedure. So now moving on to the different alternatives. Most common procedural or surgical alternatives to uterine artery embolization are going to be hysterectomy. This is by far the most common one. That's when complete removal of the uterus. And myomectomy is when we remove just the fibroids that are causing the problems. It's a little bit hard to compare all of these together, and even hysterectomy and myomectomy even to each other or even to themselves, because there's so many different methods by how they can be done. A hysterectomy can be done open, which is what's shown on this top picture. They make an incision in the pelvis, and they expose the uterus to take the whole thing out. It can be done laparoscopically, which is what we're showing on the bottom image, which is just like any other laparoscopic procedure. They inflate the abdominal cavity with some gas, usually CO2, and they use these small incisions to stick these laparoscopes or a camera and other instruments through, and they can sometimes get the uterus out that way. And if the uterus is small enough, then they can actually sometimes remove it vaginally. Your gynecologist is really going to be, if you're going to go through a hysterectomy route, they're depending on different factors, the size of the uterus, the fibroids you may have, do they think there's cancer or not, and what their personal kind of expertise is, if they're more comfortable with one method versus another one, because that definitely plays a role. That'll often determine which one of these methods are we going to use. Oftentimes when the uterus is removed, the ovaries are also removed at the same time. There is some debate as to whether or not this may increase risk of heart disease, which obviously is a major problem if it does, because heart disease is the #1 killer of people in this country. And they initially it was very common to take out the uterus and the ovaries together. Once they thought that there may be an increased risk of heart disease, which they thought was due to the hormonal changes that happen after you remove the ovaries, they thought, well, maybe we should not remove the ovaries routinely. We'll keep them in place. And that hasn't really seemed to make much of a difference. The problem is we haven't even shown conclusively that this even has any effect on heart disease. There's some research that shows that it does, and there's some research that shows that it doesn't. So unfortunately, we don't really have a good reason, a good argument for or against that. Hysterectomy does tend to be, of all the different options that we have, the most invasive by kind of a long margin, and it also has the longest recovery, which kind of they go hand in hand. But I'm not saying it's not a good option. There are definitely situations where a hysterectomy may be the best option. If somebody says, I just want the thing out, I don't want to have to deal with it anymore, just take it out, I don't want to ever have to think about it anymore, hysterectomy, not a bad option. If you have very, very large fibroids, hysterectomy is a pretty good option. Sometimes what we do in these situations, in order to help limit how large of a scar that you're going to have and to make it perhaps a little bit easier on the surgeon who's going to remove your uterus, is we'll actually perform a uterine artery embolization to try to shrink down the fibroids in the uterus a little bit, and then wait some time, maybe about a month to 3 months, and then they'll go in and do the surgery thereafter. If it's unclear what's actually the cause of bleeding, probably better to just take it out in case there's a cancer that may be involved, or if the doctor just has a suspicion that maybe there is a cancer, better to just take it out. Myomectomy is when they remove just the fibroid. And again, this can also be done open. They make an opening and they take out just the fibroid and they stitch the uterus back together. Laparoscopically, just like before, they make small holes and they take out just the fibroid. And if the fibroid is predominantly on the inner lining or in the cavity of the uterus, then they can sometimes do it hysteroscopically, which is vaginally, like seen in this picture here. This is going to, again, depend on the location and size of the fibroid. And this is not a procedure that I do because I'm not a gynecologist, but from my understanding is this is technically, not necessarily always, but can be more challenging than a hysterectomy. And so a lot of it is going to depend on local expertise and whether your doctor is comfortable doing this or not. This does have a shorter recovery than hysterectomy, and so that's the one definite advantage, but it can be more technically challenging. So now to compare all three of them together, they all actually have very similar short and medium term control of symptoms. As far as bleeding rates go, hysterectomy is going to be the best, which is obvious. You don't have a uterus there to bleed anymore, so it's not going to bleed. But they all have, very importantly, equal satisfaction rates, despite whatever outcomes you're going to get, which are maybe slightly different from all three procedures. When they asked women after the procedure at various time intervals, they've all expressed equal satisfaction rates, all of which are around 90%. Here we're going to go line by line, talking a little bit more about comparing the different procedures. So in both uterine artery embolization and in myomectomy, we're preserving the uterus. Obviously, in the hysterectomy, your uterus is removed. So the uterine artery embolization, like I said, very small incision in the wrist or in the groin, so it's not very invasive. Hysterectomy is generally the most invasive, and because there's so many different ways to do a hysterectomy and myomectomy, I'm kind of averaging them all together. Otherwise, it would make a very difficult slide to make. And myomectomy is moderately invasive. Uterine artery embolization, most commonly nowadays, we're doing it as an outpatient procedure. But like I said, sometimes you'll stay for one night, very, very rarely over one night. Hysterectomy tends to be a several-day hospitalization on average, although I hear you can do it as an outpatient now, but I don't think that's very common. And myomectomy is usually 1 to a few days in hospitalization, but again, it can be an outpatient procedure in certain circumstances. Recovery tends to be fastest with uterine artery embolization, and it's usually about 2 weeks, like I said earlier, whereas a hysterectomy, particularly I'm talking like an open hysterectomy here, can take 2 to 3 months, and a myomectomy is usually somewhere in the middle, 2 to 6 weeks. This is assuming non-hysteroscopic, which is the vaginal approach where they simply remove a fibroid that way. That's usually just a few days. But otherwise, the laparoscopic and open techniques, 2 to 6 weeks. Both uterine artery embolization and myomectomy have a lower infection risk than a hysterectomy, which makes sense. Less invasive a procedure, usually the less risk of infection. Hysterectomy has the highest of the three, but I'm not trying to make it sound like it's a dangerous or high risk of infection. It's still, thankfully, a low risk of infection. Uterine artery embolization has almost no bleeding. The amount of blood loss is almost completely negligible. This is actually one of the reasons why sometimes we see Jehovah's Witness women prefer to have uterine artery embolization because they may not want blood transfusions just in case they have too much blood loss. So that's one of the reasons why we actually do uterine artery embolization in those women. Hysterectomy is usually associated with the most blood loss because it is the most invasive, and myomectomy is, again, somewhere in the middle, but closer to hysterectomy than uterine artery embolization. As far as expense goes, uterine artery embolization tends to be the least expensive for both the patient and society as a societal cost, whereas hysterectomy and myomectomy are a little bit more, with hysterectomy being the most. This is assuming that we don't have to do any repeat procedures for either uterine artery embolization or myomectomy. If you do have to do a repeat procedure to try to kind of finish the job off, then it tends to be similar to a hysterectomy, maybe even actually a little bit more. Because we're preserving the uterus in both uterine artery embolization and in a myomectomy, it is possible to become pregnant afterwards, but with a hysterectomy, of course, you cannot become pregnant. And something I alluded to before, we're treating the fibroids in the uterus that are there at the time of the procedure. So it's possible, if you're of a certain age, depending on what age you get the procedures done, that you may develop new fibroids. You had fibroids before, you're at risk for developing more fibroids. And those fibroids can be in that 75% of women who never have any symptoms whatsoever, or they can again be in the 25% of women who do have symptoms, and so you may require another procedure down the line. And so this is just quotes from one study that looked at years down the line. And despite this number being much higher than that one, what they actually found is the rate of women who required a second procedure is actually almost identical in both of these two categories. And this is what we just talked about. So here's an example from one article that compared uterine artery embolization in one category to, they kind of lumped hysterectomy and myomectomy into another category, and how many days it took to perform certain activities. So uterine artery embolization is in the left column, and hysterectomy/myomectomy in the second column. Although I will tell you, most of the women in this research study were hysterectomy, but there were some myomectomy as well. So hospital stay, like we mentioned before, 1 day versus 5 days. When you were able to make a cup of tea, day 2 versus day 6. And so they're kind of going through typical daily activities. When you were able to cook a meal, 6 days versus about 2.5 weeks. Drive a car, 1 week, 1 month. Return to work. And this was done in the UK. So they took about just under 3 weeks for uterine artery embolization and about 2 months for surgery. And when we were able to have intercourse, 3 weeks versus just under 2 months for surgery. So people may be wondering, does insurance pay for this? It sounds great. I want to get it done, but I don't want to pay for it. Will insurance pay for it? Nearly all insurance companies pay for uterine artery embolization. This is not some type of experimental new procedure. This has been around for quite some time. There is level 1 evidence, which is the highest level of evidence that you can get for a medical procedure, that this absolutely does work. And so it's generally accepted that if you need it, they'll pay for it.
How long has it been around about?
A few decades, about maybe 2 or 3 decades now. I want to say early 90s is maybe when the first one was done. They used to do this procedure more initially for emergencies, people who were having bleeding from pelvic organs, and then somebody had the idea of, well, what if we do this electively? And so that's kind of when we can say the first uterine artery embolizations were purposefully done. And another thing I want to add is you don't necessarily need a referral to have these procedures done. You can simply call. Of course, that's kind of depending on your insurance. Some insurance companies require you to have a referral from your primary doctor, but if you don't, then you can certainly call an interventional radiologist. But if you prefer to go through your doctor, that's absolutely okay. And so you can go down that route as well to get a referral from your either primary doctor or your gynecologist. Other reasons we do uterine artery embolization, the adenomyosis, which is one of the causes of abnormal bleeding I mentioned at the very beginning, the inner lining of your uterus starts growing through into the muscular layer. While uterine fibroids have a 9 out of 10 success rate and satisfaction rate, adenomyosis not quite as good. It's only about 7 out of 10. But the only other real alternative is to completely remove the uterus. So if some women really don't want to have their uterus removed, so we can argue that maybe we can try the uterine artery embolization, and if it works, great. And if not, then you can move on to plan B. Some women who've had recent childbirth and they just simply won't stop bleeding, you could simply remove the uterus and that usually works, but again, especially if that person wants to potentially have future kids, we can often spare the uterus by doing a semi-emergent uterine artery embolization. And women who have uterine or cervical cancer that just won't stop bleeding, not necessarily you're gushing out blood, although that can be the case, but just bleeding that just simply won't stop, causing you to become anemic and going into the hospital for transfusions or monitoring. we then can do the procedure. Even though I said earlier, we don't do it for cancer, this is a different scenario. We're not trying to cure the cancer. In this case, we already know there's cancer. This is usually, there's not really much more options. There's no surgical option. There's no chemotherapy option. We're just trying to really make you comfortable and stop that bleeding. So in summary, uterine artery embolization, high rate of technical and clinical success. It can help with symptoms related to both bleeding and bulk, meaning compression against nearby structures. Equal satisfaction rates with hysterectomy and myomectomy. And it does have the fastest recovery rates compared to those other procedures. What I tend to tell a lot of my patients who come to see me in the clinic about whether or not they should do this procedure versus doing one of the other procedures is it does have the fastest recovery rates. And in the very beginning, I talked about what is important to you. Let's say you have a job where you can't take 2 months off of work and you really need to get back to work quickly. Then uterine artery embolization may be the better option for you. Another argument that I have for uterine artery embolization, although I will admit I'm going to be biased based on that I'm the kind of doctor who does this procedure versus the doctors who do hysterectomy and myomectomy, is this is the least invasive and it does have the lowest complication rate, although thankfully they all have low complication rates. But you could try this procedure. 9 times out of 10, you're going to be very happy with the results. If it works, great. We're all very happy. If it doesn't work, yes, we're going to be bummed, but we haven't inhibited your ability to move on to any of the other more invasive options. So if you're up for it, let's give it a try. If not, there's nothing wrong with going for hysterectomy or myomectomy. If you think that's what's best for you, go for it. That's often, just like I said, they all have equal, generally, satisfaction rates. You're going to probably be happy no matter what you choose, as long as the different factors in terms of recovery and the other, technical factors and the factors of things that you want to be able to get back to doing more quickly are okay. If you're okay with that, then you can do that. But uterine artery embolization tends to be often overlooked or ignored because a lot of people in the general public are not very familiar with it, which is one of the reasons I wanted to have this discussion today. And I can tell you, even within the medical field, there's not a lot of familiarity with it outside of interventional radiologists like myself. And so this is just one step of hopefully multiple steps where we try to kind of bring out the word so that everybody can make the decision that's best for them. Thank you. Yes, ma'am.
I have 2 questions. One is, what are these small particles made of, and do they get absorbed by the body? Or?
Sure. So the best way I can describe it is kind of like a medical grade plastic. And traditionally, we actually used to use non-resorbable particles, and still worldwide, that is going to be by far the most common type of particle that's injected. You'll never feel them. You'll never know that they're there. They just over time, your blood pressure is just going to continue to push them forward until they get packed really, really far into the arteries. And then if you ever went back and did another angiogram where we inject the contrast dye and look, sometimes you can't even tell that what looked like was completely blocked on the day of the procedure. When you come back, months or years later, if you ever came back for some reason, it'll often look like you never really did anything at all. The arteries will slowly start to open back up and the body will create new channels to supply the uterus. And that's why the uterus doesn't completely become defunctionalized. There is a very new product that just was recently put onto the market, which is an almost identical type of bead or particle, but these, after about 3 months, they completely reabsorb by the body. And so they're not there. And so that's actually what I've recently started using on a trial basis, just to see. Other people have used them before for this exact procedure, and they found so far in small scale studies pretty much equivalent results to what the beads that we were using before. And a lot of people say, well, yeah, if I could have a particle that is eventually going to be completely gone, I would prefer that. Even knowing that the other particles, they're not really going to cause any major problems. We've been doing this for years, and nobody has really ever come back to my knowledge and had any issue with particles being embedded in their uterus. But yes, it does sound better if we could use resorbable particles, so we're giving that a try. Yes,
Does the body ever recognize these particles as foreign bodies and try to reject them?
Not that I'm aware of. I've never heard or read of any incidents of that. I'm sure at a microscopic level there probably is some type of reaction that's going on, but I'm not familiar with anybody who's ever required some type of procedure because the body has had a kind of a rejection to these particles. And I've never heard of anybody who's had an allergic reaction to these particles either. Any other questions? Yes, ma'am. Oh, sorry, yeah, you had a second question, I forgot.
How soon after the women are returning their menses? How soon after they start menstruating?
So it's kind of variable from person to person. So assuming then bleeding was kind of your predominant symptom that you presented with, the bleeding doesn't necessarily immediately stop. You can still have some blood even for the few days after the procedure, but then usually it will stop. And then it kind of takes the body sometimes a little bit of time to readjust and recalibrate. And so sometimes even just your next normal menses period, it'll come on normally. And for some women, it can take 2 to 3 months, and then it'll start back up again, assuming that, again, you weren't pushed into menopause. All right, if that's it. Oh, we got one more. Here we go.
Can you do this under MAC anesthesia?
You can, and that's actually, I didn't bring that up. So we actually typically do this under just conscious sedation. So you're not asleep for the procedure. We put an IV in your arm, and we give you medicines to do the procedure. Medicine, one is an anxiety medicine, and the other one is a pain medicine. And then usually throughout the procedure, especially once we start actually embolizing or blocking one of the vessels, we start really hitting you with really high doses of stronger medications. Because like I said, the procedure is not really painful, that's sufficient for just about everybody. But if you're the kind of person who has really high anxiety levels and you really don't think you're going to be able to lay on the table for about 1 to 2 hours and you're just going to really be uncomfortable the whole time, then yeah, we could definitely do it under MEC. But having said that, I've never had to do that before, but it certainly is doable. Yes, ma'am?
It's not really about the subject, but similar to it. What do you think about the uterus transplant thing that they did this week with the donor?
So I just got to say real quick, I forgot, I was supposed to be repeating all your questions, so I'm sorry that I didn't do that. But your question was, what do I think about uterus transplant? I'll be honest, I was not aware of it until you just mentioned it, so I don't think I can comment on that. Okay. That does sound very cool, though. All right. Any other questions? All right. Thank you all so much for coming.
Heard about this, I really appreciate hearing about it.
Thank you. Thank you.